All right, we're ready. We're recording. What did you say? So let me have a show of hands. In all honesty, a show of hands. Who feels comfortable with their introduction to the brain stem at this point? All right, we're okay. Good. We're going to go through every freaking detail. No, I'm joking. I'm not. I can't do it. I had gross lab this morning. I had to shower after because we were doing the thoracic cavity. And so I don't think I have it in me. So I skinnied the lecture, but I left you the resources. No, it'll be okay. So here are your learning objectives. Again, I've decided this year I've put in links to where those places are, because sometimes you just open something, you just forget one thing, and you want to just go right to it. So there we go. Now, I'm going to ask you a question you know the answer to. Which vesicle did the medulla oblongata come from? Five, four, three, two, one. Okay, good. Most people got it right. The myelencephalon. Remember, it's the ABC, the end of the alphabet, the last one, myelencephalon. All right. So it came from the hindbrain is actually inclusive of the metencephalon and myelencephalon. So it was a division of the hindbrain that actually occurred because of that Pontine flexure. The Pontine flexure is going to make the alar and basal plates kind of rearrange themselves, but it also is going to allow for expansion of the ventricular system in that region. Now, the medulla oblongata, a lot of times when you're looking at a specimen, it's hard to kind of point out where it starts. If you can find the most upper cervical roots, so you see those organized roots coming off the spinal cord, and then you get to the brain stem, they don't come off in that organized pattern. Well, look at the very first ones that come off the spinal cord because they're organized in that pattern, and that's C1. And so if you go superior to that, that's where the medulla oblongata is supposed to start. It's somewhat of an arbitrary point, but that's the anatomic point. So the fourth ventricle is the cavity inside some part of the medulla oblongata, and it's kind of shaped somewhat in a 3D diamond shape. And what happens is not actually expanded throughout the entire part of the medulla oblongata. So you end up having two parts to the medulla oblongata that you can tell the difference when you're looking at a cross section. You have an open part that is part that surrounds the fourth ventricle, and you end up having what's called a closed part, which is the part of the medulla that is before the ventricular system flares into the fourth ventricle, or after, depending on which way you're going, you're ascending or descending in the brain stem. Okay? And so the closed part is referred to as the central canal of the medulla oblongata, and it looks like the central canal of the spinal cord, and albeit is oftentimes kind of nondescript when you're looking at a brainstem section. So you might just think that it looks somewhat like the spinal cord, and maybe I am in the spinal cord, but you'll see other features that sort of give it away, that you see different nuclei that are not shaped like the dorsal and ventral horns of the spinal cord, and then you can think, oh, you know what, darn it, this must be the medulla oblongata, and that's probably right. So now, one interesting point is, so it looks a lot like the spinal cord, but the alar plates are not going to behave themselves, and they're actually going to migrate into what was the marginal zones in the spinal cord. So in the spinal cord, you had the marginal zone around the outside of the plates, and that zone had axons in it. It was made up of axons. It was white matter. But in the medulla oblongata, although a lot of it, the lower portion of it is shaped like the spinal cord, you have migration of some alar nuclei into this marginal zone. And those are going to be actually associated. Those are the nucleus that the dorsal column fiber tracts are headed for to synapse with, okay? So those fasciculi that you talked about yesterday, the gracile and cuneate, are going to those tracts are going to come up, those axons are coming up to synapse with these nuclei that came from the alar plate of the developing medulla oblongata, okay? They went out in the marginal zone. It's a very unique feature. And then on the ventral side, I alluded to it, this is one of your general rules, that the corticospinal tract is always going to be most ventral. And in the medulla oblongata, they make elevations in the wall that we call the pyramids. That's the elevation of where the corticospinal tract is located at. All right, we're starting to lay down some laws here. Whoops, that was not what I wanted to do. But it's what I did, so here I can't go back. All right, so what signals again do All right, so we're laying down the beginning rules. Now we have this cuneate nucleus that's coming from the alar plate, so it's receiving afferent signals. And then we have the gracile nucleus. And they're paired, there's one on each side. Which one is coming from upper body, upper cervical information from the upper body? Cuneate, right? And the gracilis is going to be the one coming from the lower body. Which one is lateral? Cuneate, okay, good. Just, you guys got this down. Not worried at all. All right, so what signals, again, do the corticospinal tract carry? Does the corticospinal tract, the ones in the pyramids, that's carry? I do stop asking you these questions eventually. This is the only time I do this. All right, so the answer is motor to skeletal muscles, or motor to the alpha motor neurons, or motor to the spinal cord. I don't know what he said yesterday, but when I think of it in the end, it's the motor to skeletal muscles. But all right, so we have this open part and we have this closed part of this medulla. All right, we have the Pontine flexure. You can't see the flexing that's occurring. And we have the growth and opening of the fourth ventricle, and it's going to move these plates, the position of the plates. And so here you can see this is open, and you expect to see this configuration when you're looking at the open part of the medulla, and you expect to see something like the spinal cord when you're looking at the closed part. And so here we have this figure where you can see how the development caused displacement of the alar and basal plates, so that the alar plates end up being lateral and the basal plates end up being more medial, which take their functions with them. So the afferent nuclei that are developing from these plates develop laterally, and they don't move afterwards, they stay there. And the nuclei that are in the more towards the midline of this medulla oblongata are going to be motor. And this is the same pattern that's going to be through the pons in the midbrain. This is just the first one we're talking about. Okay? Now, if there's the midline and I'm only looking at motor in this section, it's actually, the nuclei are even arranged columns by function. They're actually arranged in columns by function. And so you can, the ones that are most towards the midline is general, somatic, efferent. What does that mean to you? You're the first one who looked at me. What does that mean to you? You can be wrong. Like skeletal muscle. Okay, so it's going to do skeletal muscle motor, right? Okay. Any particular type of skeletal muscles? So how is general, somatic, efferent? Oh, wait, I have a quicker question for that, so maybe we shouldn't ask that. Okay, we'll just go with that. You're right. You're right. And so you're going to want to refresh your memory on what these functional components are. Maybe it's the next question, but I don't think, yes, it is. But what function does special visceral efferent project to? What targets do special visceral efferent neurons, if they have this function, what are they projecting to? Are they projecting to parasympathetic ganglion? Are they projecting to sympathetic ganglion, motor to muscles of pharyngeal arch, or special senses? So efferent motor. I already gave you probably half the answer. Most of you should get this right. All right, 5, 4, 3, 2, 1. Muscles of pharyngeal arch origin. Do you see these? I know. Those functional components that just seemed very irritating in gross anatomy actually are going to make more sense now. Because down the midline of the dorsal part of the brain stem lies nuclei that do general somatic efferent, muscles of the head that are not pharyngeal arch origin. So you have to know which ones are to know which ones aren't. But it sure does make it easier to identify nuclei on the midline. It does, it really does. I'm not joking. Because if you know what cranial nerves are in what part of the brainstem, and you know which ones are that functional component should be midline, there you go. I don't even need to teach the rest of this lecture, because you have almost all the information to put things together. But you can also just use the guide that I gave you to study off of, and you'll get that too. All right, so you did that. Now, those functional columns that I showed you are right here. Here's the midline, and here they are. And lateral to that, although they're not really, really big like this, although sometimes they are significantly bigger than the motor ones, are the afferent nuclei that are also lined up in categories. It's a little trickier with afferent. It's true in some places of the different brainstem where these categories are, well, yes, this one's lateral to this one. Okay, yeah, I'm going to lay down that law. But not all of those types of nuclei are present in all the sections. So for me, what I find most helpful is remembering that motor is towards the midline and sensory is lateral. That's definitely easier. And then also that of motor, because you're going to have some more than one motor nuclei at a time, the ones that are going to muscles that aren't pharyngeal arches are the most towards the midline. Those rules really help me a lot more than memorizing the organization of all of these columns. Okay? And the only last thing that is pretty darn helpful is that this one is the very, very most lateral, which is special somatic afferent. And which of the following senses is considered special somatic afferent? Got it? All right, 5, 4, 3, make a guess, 2, 1. Okay, good. Most of you put hearing, and that's true. Hearing, vestibular function, sight are all going to be special somatic afferent because you have this physical change, this change that's occurring. Hair cells are moving. You have a conformational change in the retinal cells as well. And that's in contrast to taste and smell, where there's a chemical synapse. So that wouldn't be special somatic afferent, it would be special visceral afferent. But all I have to remember is those special somatic afferents are most lateral, because there's some times when there's a whole bunch of nuclei in a big group, and I'm struggling to remember whether it's this one over here or that one over there, and I know if they do that function, and that's what I'm looking for, it's the most lateral. Okay, so those are kind of the three things that really help me the most when it comes to those columns, instead of sitting there and memorizing every single one, which is probably not going to be very fruitful for you. Okay, so in addition to these columns that occur in the medulla and this widening, well, I just put that there for orientation, the alar plate has some neuroblasts that come on the ventral part of the brainstem. It's not only in the medulla, but it starts in the medulla, and these develop into the olives that Dr. Ferris has introduced to you several times. I do have some information in the lectures about the olives, and they're easy to identify, and so I kind of downplayed a little bit. And some of the functions really kind of are integrative relay stations, and they fall into that other category that I don't go too much into, but other people will, okay? All right. So this is what you end up with. The medulla looks different depending on where you are. A lot more to me than the other two parts. So closed, open, this is sort of just a summary slide, okay? All right, so where is the medulla? Let's make sure we're on the same page. I think we all are, that it's going to be the most caudal part of the brainstem. It's just inferior to the pons. It's just superior to cranial nerve roots from cranial nerve 1. And it is going to be inclusive of the inferior part of the fourth ventricle, the part of the ventricular system. So what cranial nerves are only associated with the medulla? That's it. Only the medulla are, and so if you have a lesion in one of these cranial nerves, you're thinking right away from the beginning, medulla oblongata, cranial nerves 9, 10, and 12. Easy, easy. 9, 10, 12, medulla oblongata. If you got a lesion there, and it's not just like a lesion peripherally, then in the brainstem, you are being clued into the medulla oblongata. Now, in a lot of places, you will see cranial nerves that are associated with the ponto-medullary junction given to the medulla or associated with the pons. It's really irritating as an anatomist because the different resources that you use associate them in different places. I have a little, does this work if probably not. I have a little tangent, which you know I sometimes do these offshoots, to give you a little explanation about why we talk about it that way, okay? I'm not going to read it for you right now, but you can read that and understand, oh, okay, well, I get it. But for all intents and purposes, they don't only belong to the medulla. All right, so don't forget about where it's positioned. Look at a medical image. Just pull one up. Look at an MRI of a sagittal brain and find the medulla oblongata. We're going to do that in lab, but do it before lab. Okay, grossly observable features. There are lots of structures here that we will learn in lab. The pyramids are your home base. Lateral to the pyramids, you have those projections that are representative of where the olives are, and you have sulci in front of them and sulci behind. These aren't just random memorization points. Cranial nerves come out of these sulci. So it's going to help you identify where cranial nerve 12 comes out versus 9, 10 that come out here laterally, okay? And I'm not going to point all these things out to you because that's boring, and you can go through a lot of the material through the activities we do in lab, and it's more fun because you have a specimen. Okay, and then on the dorsal side, we'll also learn these points in lab. You will see some of the medulla, as you would expect, at the inferior part of the fourth ventricle, and some that looks like it's closed up and joining the spinal cord. And that's true, and we expect to see that in cross-section as well. So you already know this information, but let's ask it in a different way. Which of the following lists is derived from the alar plate and the medulla? You don't know what all these nuclei are, but you can still tell me the right answer because you know some of them. Is it list 1 or is it list 2? Ooh. Make a guess then. 5, 4, 3, 2, 1. Okay, so most people put list 2, but a significant amount of people put list 1. Alar plate. What's alar plate? Sensory. Okay, sensory. We don't know what some of these are, but what does the hypoglossal nucleus do? What does it do? I heard someone say it. Moves the tongue. Motor to skeletal muscles of the tongue. You're done, right? That's motor. List 1's motor. List 2 is sensory. So list 2 should be right. But I'm showing you how these collections go together because I already told you the alar plates are lateral and basal plates are medial. So you already are expecting these structures to be more towards the midline than these structures, considering all of them will be found somewhere in the medulla oblongata. I want to point out and not have everything a cartoon image that these things are real. And when we looked at the microscopy of some of the central nervous system, hopefully you can remember that the tracts that we talk about now are actually axons. So we'll see axons when you look at these close up versus the nuclei having cell bodies in them, neuronal cell bodies. And remember what those look like from histology. That concept has not gone anywhere. When we say tract, we mean axons, and when we say nuclei, we're talking about the cell bodies. And you can see this for real when you look at a microscope slide. And you will see them, virtual slides, throughout this course, and when they talk about normal and pathologic brain. Okay, And so the medullary ventricular system, there's the central canal and the closed part, and the fourth ventricle in the open part. Arterial supply of the medulla. This is high ticket stuff because I already talked to you and showed you how these lesions are figured out. You know where the nuclei are, you know where the blood vessels come in, you already know your test questions essentially, okay? So what vessels bring blood to the medulla? I hate to break it to you, but there's got all these sides and there's different vessels coming, so it's more than one. All right, so we have these small penetrating branches that come off the vertebral arteries. Some come off the anterior spinal artery. And so we have one of the circumferential paired arteries that come off the vertebral arteries called the posterior inferior cerebellar artery. So that's going to go and be associated with the most inferior part of the brainstem. But unfortunately, the artery that's associated, that's one level up, is the anterior inferior. So like I said, in lab, you're going to really be able to tease out these arteries better than I can show you on a 2D image right now. And then the posterior spinal artery is an artery that Dr. Ferris talked about yesterday, bringing blood supply to the dorsal columns. It also plays a role in the medulla because those dorsal columns, that dorsal side is coming up into this area of the brainstem as well. All right, and so here you can see a schematic of the posterior inferior cerebellum artery coming on the inferior part of the cerebellum. We'll go over this again. All right, so there are named ascending pathways that are coursing through the medulla. They're coming up and they're bringing sensory information through the medulla to go places, and that's depicted in red. One of them, which is the medial lemniscus or the anterior lateral system, okay? Those are all valid. There are in the other categories, like spinocerebellar tracts. You'll learn more about why they're doing that later, but you're gonna see them labeled on pictures, and it kind of gets overwhelming. But we're gonna target you to the ones that are high yield at the beginning, and you'll add those in as you go through the course and learn about more functions about the brain, and especially the cerebellum. All right, but then there are also ascending tracts that are going to end up synapsing in the medulla, and you'll learn about those later on as well. So not everything just passes through. And then you also have descending pathways that are coming down through, like the corticospinal system, but you also have other systems that you'll learn more about later. I'm just setting you up with the terms, and I have some very overview information in my PowerPoint study guide for you. But like, give you an example of axons that come down and terminate in the medulla. The corticobulbar are fibers that are motor fibers to cranial nerve nuclei in the brainstem, and the last ones have to terminate in the medulla because the brainstem's done, and the cranial nerves are done. So the very, very last corticobulbar fibers are going to terminate in the medulla. So there are descending fibers that pass through, and there are descending fibers that synapse as well. Is the medial lemniscus a descending or ascending tract? Pull is open. Let's do this fast. 10, 9, 8, 7. Wow, you're doing it fast. 6, 5, 4. Good. All right, ascending, great. So I just want to, sorry, I didn't count that down. I just want to bring that last terminology in there with you. Okay, we have these sensory motor, ascending and descending are also terms that you should start to put together with sensory and motor. Although that's not always the case at this point in time, it would be good for you to think that way. All right. Medullary structures by anatomic region. The medulla is different because it's got a closed part, it's got an open part, and it has some really special things that happen in this part of the brain stem. So when you look through textbooks, and they don't always have the same exact section in an atlas, okay, but these are just some classic sections through the medulla. All right. I have slides that have more nuclei, I can't say all, that have kind of a lot more nuclei and tracts on them for each section, okay? But I gotta start somewhere, okay? And I also have little information tidbits on the links about the nuclei to help you. I can't say all of this stuff right now, but we can talk about some big ticket items. All right, the first most caudal section that is oftentimes taught in the medulla is the motor decussation. So you have these corticospinal tracts that are coming down through those pyramids in the medulla. Okay, let's just do that because we're in that region. And before they leave the medulla, the most inferior part, they're going to cross to the other side. Okay, and so that is depicted here in purple. And just to show you an example of one of my slides here, if you click on motor decussation, I give you a little more information about what that means, okay? So you can look through all of this stuff later, although I'm not going to necessarily tell you all of it right now. So that is the area here that's in purple. And it isn't always obvious when you're looking at an anatomic section. So I like to put in a drawing, and I think it's really easier to start off that way when you're learning brainstem anatomy. Because it's hard enough to know what should be over here versus what should be over here. How do I know this is the motor decussation? Well, there isn't any corticospinal tracts. There's no pyramids depicted in this picture. And also, I know I'm really far down because of can you see this pointer on media side or not the pointer? Okay. Because it's easier for me to do this for right this second. That you can see that the nuclei, which is the gracile and cuneate, this is the cuneate and this is the gracile nuclei, are depicted in these locations. Remember, they went to the marginal area from the alar plates. You can still see parts of their fasciculi here. You can still see parts of their tract. They haven't all terminated on the nuclei yet. So those are the two reasons why I kind of can feel like this is the motor decussation. Other points at this, other anatomic nuclei and such that are at this level, we're going to introduce you to these nuclei, are some nuclei here. Now, these nuclei, would you expect them to be motor or sensory? Motor, okay, because they're close to the midline. And so the hypoglossal is the most medial nucleus. You know it's only associated with the medulla. And then right next to it, its friend forever, is the dorsal motor nucleus of vagus. So they're right next to each other in the midline of the medulla. The spinal trigeminal tract, of course, Dr. Ferris introduced you to this yesterday, is going to show up right away because the continuation from the spinal cord, what was the continuation for, Dr. Ferris? The substantia gelatinosa. So it is going to transition into the trigeminal because the trigeminal is bringing in all the sensory information from the head, if you remember that correctly. All right. And then the other big ticket item that you want to hold on to is that anterior lateral system. And that anterior lateral system is going to be laterally and mostly dorsally throughout the brainstem, and you're going to want to follow that friend throughout the whole brainstem. It's just like a little blob that's out there, and its rubrospinal tract is its friend, and it kind of links onto it for quite a long time. So these are the big ticket items. You can look at the full slide that has more nuclei and tracts when you click on here, and then you can go to some of the ticket or the titles here, because I'm not going to talk about this right now, but it gives you a little bit of information about it, just to give you something to hold your hat. Yeah. Okay. That's going to go back there. That's not what I wanted, because that's a return. As an error in my system. I got ahead of myself. Okay. Now, if I go up one level, still in the caudal medulla, but there is a sensory decussation. So now we have a crossing of fibers, but it's not the corticospinal tract. Actually, what happens is that these nuclei, the gracile and cuneate nuclei, are going to cross their fibers and become the medial lemniscus. The medial lemniscus. So that's why these words get linked up together. It's the same system. They just call them different things after anatomic changes have occurred, okay? And the medial lemniscus was that system that is going to be standing up and then lying down and then put your feet up, okay? So it's going to change shape throughout the course of the brainstem, but here in the medulla oblongata, it's standing up and down. Now, the fibers that are coming from the nuclei, gracile and cuneate nuclei here, are called the internal arcuate fibers, okay? The corticospinal tract, because we are above where the motor decussation, we have the pyramids. Remember, these fibers are going down. That's where the corticospinal tract is, and will probably stay for the rest of the brainstem because you're going all the way up to the cortex now. Those fibers were projecting the opposite direction. And now we have some new players here. We have the nucleus ambiguus, which sits kind of out in the middle. Like think of the nucleus ambiguus like an island, this fancy island I want to go to and spend a few months there. I went at the nucleus ambiguus. The nucleus ambiguus is involved with the glossopharyngeal and vagus nerve and is important for laryngeal muscle coordination. And so in the end to all function, it's important for swallowing and speech. So when you have, it also has some autonomic function, I talked about that, but that is very much downplayed. It's mainly speech and swallowing is the function. And I have a slide on there to give you a little more information. So the nucleus ambiguus is going to be here throughout the medulla. It's be here a while, okay? So you're going to see that in a lot of sections. And then the other nucleus that is going to be introduced to you right now is called the solitary nucleus or the nucleus solitarius. The nucleus solitarius is a visceral afferent nucleus. So all the visceral afferents that are coming in from the head, so cranial nerve 9 and 10, are coming into the solitary nucleus. But that's not the only thing that it does. As you go more and more rostral up really high, there's a part of it that's called the gustatory nucleus because that's where the sensation of taste comes in. Okay, and so it's also a good nucleus that's going to be here throughout the medulla and the caudal aspect of the pons. All right, so we've been introduced to those players. Those players are going to continue for a while. But the new players here, as we go up to the mid-medullary level, now I know this is the mid-medullary level because I have flaring and opening into the fourth ventricle where the last section was closed. All right? And also I have enlargement of the olives. The olives, which I give you some information on. It helps you identify where you are and you can see them easily, but we're not going to talk too much about their function until we talk about the cerebellum. All right, so the new players here at the mid-medullary level, we all have all the other stuff. We have the medial lemniscus and we have the nucleus ambiguus still, but we have some new ones come into play. The vestibular nuclei that are depicted here in green, they actually are they're bigger, they course longer than the cochlear nuclei. They're in slightly different positions, but they're pretty close to each other. But the vestibular nuclei are going to start earlier and end longer. So they start lower and end up higher. And then the restiform body. The restiform body is kind of circled as if it's a nucleus, but it's really a part of the inferior cerebellar peduncle. The other part's a juxtavertiform body, but the restiform body is a bigger part and it starts further down. So at the mid-medullary level, you still have a lot of the other players. If you look at the full slide, it shows you all of the nuclei on there, but I want to just show you the new players here. When you go up to the rostral medulla, it's rostral, so the higher up, highest up, we have some new players here that are also important. The inferior salivatory nucleus, okay, that is depicted here in red. Would you think that this nucleus here is going to be motor or sensory? How many people say motor? Ah, good, that's the right answer. Okay, it's motor, it's pretty close to the midline, right? Inferior salivatory. What does salivatory mean? Makes saliva. What motor function makes saliva? GVE, right? Parasympathetic stimulation. So the inferior salivatory nucleus is parasympathetic motor. What cranial nerves are going to handle salivation? You got 2. 7 and 9. Which one's inferior? There you go. That's what it does. Okay? That's what that nucleus does. The only thing it does. Well, it might do other things, but the only thing that I know that it does. I'm sure they know other things. All right, and then now laterally, super, super laterally, because it's special sensory, right? The special somatic afferent, most lateral is a cochlear nuclei shows up, okay? All right, I said vestibular nuclei before and I meant cochlear. I take that back. The reticular and Raphe nuclei, Raphe, you say Raphe? Raphe nuclei. I know that Dr. Ferris mentioned it briefly yesterday because he talked about pain signals coming into the spinal cord, and he talked about how they can be modulated. And so I have little blurbs, I have little tangents on each one of these nuclei, and talk to you about how they're widely distributed, just because I don't want to say things, but then, and you see pictures and books and it has words in it and it seems important, but yet we don't mention it. If those are in the other category, and they will be brought up when other professors talk about these integrative functions later on in the course, but they are throughout the brain stem, okay? So don't get confused with these. Now, the medulla has blood vessels that bring blood. These are the high-ticket items, test question items here. Vertebral artery branches into two important vessels for the medulla. The anterior spinal artery, and there's going to be little branches that come off the anterior spinal artery just to the medulla, and the posterior inferior cerebellar artery. All right, and so I showed you that where they're located at. Here you can see the anterior spinal running down the midline here, and this is the posterior inferior, and this is the medulla. So they're right next to each other, but you can see one's going around the lateral dorsal aspect and one's running down the ventral aspect. So you can understand that that is probably not going to mean that they go to the same places. And then the posterior inferior cerebellar artery has branches called the posterior spinal, which is going to run down more the midline on the dorsal side. So all of these arteries are going to supply different parts of the medulla. So you end up with these classic cases that have similar symptoms because the vessel that's blocked or occluded is servicing particular nuclei. So for example, here in inferior alternating hemiplegia is kind of the one that I know it as the most, but your textbooks had a couple other terms like medial medullary syndrome. How do you say the first word? So, okay, so we'll just take the first one out. The textbook had additional terms in it. So if you have an occlusion of the anterior spinal artery here, that occluded area is in red, you could see how you would have the hypoglossal, the root and the nerve is running through here. The corticospinals would be spinal fibers would be affected, and also like the medial lemniscus, big ticket things that would be affected. And because you're putting together what those nuclei do, you could put together that you're going to have some clinical observations that are going to occur. And so I'm not going to go through all of everything on here because you can read it and you're going to need to spend some time looking at the nuclei that are affected and what happens in the end. But like for example, the deviation of the tongue when it is protruded, you could probably guess that if you just see the nuclei. You want to go both ways because there'll be questions where you just have the red here and you're asked what symptoms are, you ask what function is, or you're given a function and you're asked to put it back to what vessel is being occluded. And so I have a typo on that slide, but I'm going to fix it. All right, so here is a next classic case. I have a typo on that one too. Wonderful. There's nothing more annoying to me than typos. So if you have an occlusion of the posterior spinal artery, that you can see here. So here's the medulla, and here you have the posterior inferior cerebellar artery, and you can have the posterior spinal artery come off of it. And you can see how it's going to service the most dorsal, a little bit of dorsolateral aspect of the medulla. And so the trigeminal tract is going to be taken out, and part of the posterior column is going to be taken out This can even come down a little bit further. And so you can see why you would have these clinical observations, because you would have loss of pain and temperature sensation from the face because of trigeminal, and then you have from the body proprioception and vibration loss because of the dorsal column. So you can put this back together. But the typo here is not a classic Pontine lesion. That's what happens when you copy and paste slides and you didn't catch your typo when you're editing. So I apologize for that. It's a medullary lesion. And this one isn't classic Pontine lesion either.
Dr. Red,
yeah.
there's a question.
Yes. Are you always going to have symptoms, or can you have collateral circulation? You can always have anatomic variants, but these are classic lesions. You can always have lesions that are different than these, and almost always will. And these are oftentimes occlusive lesions. If you have a hemorrhagic lesion, so you have a bleeding in brainstem, it can really go into a wider distribution. You don't even necessarily attribute that just to one vessel. But this is like an occlusion of one particular vessel that causes these classic syndromes, but you can have different variants. And sometimes, and in the book, even they'll list may have this, this, and this, but oftentimes or always has these things. And so it's a little bit of a gray area, but is there anything else you wanted to add to that, Ham? No? Okay. All right, so if you have a occlusion of the posterior inferior cerebellar artery here, you can see how you have these little penetrating branches, but you're also going to lose posterior spinal. So you're going to have a bigger lesion than just having an occlusion of the posterior spinal artery. And that's called Wallenberg syndrome. And so you can see all of the nuclei that are affected in this type of lesions, and in result, all of the clinical observations that occur because of it. Okay, another thing that is important when you're talking about the medulla oblongata is the fact that an important cerebellar structure called the tonsil is nearby. And if you have downward pressure on the cerebellum, or growth, a bleed, any particular reason why you have a pressure increase in that posterior cranial fossa, the cerebellum is going to push downward, and it's going to squeeze and impinge the medulla oblongata. And this is called a tonsillar herniation. Now, I did put a lot of information about this because this is something that you need to know about. You need to be able to recognize on a medical image, or if someone says that this is occurring in a patient, you need to know why that's important. And so I did go on to a little bit of a tangent about the progression of a tonsillar herniation, although you can have them chronically. And here is a cadaveric specimen that I had that had a tonsillar herniation. So why is this forming and molding and impinging? Is because it's pushing downward, and what's downward? The foramen magnum, and it's a fixed ring. There's no give in the foramen magnum. Remember, that's a hard bone right there. And so it only choice is to squeeze inward, and it compresses the medulla oblongata. And that's what it looks like. This is an inferior view of the tonsil of the cerebellum pushing and impinging the medulla oblongata. Okay. Unfortunately, I didn't put a home button on that one. La-di-da. Oh, it'll happen. That's okay. I just need to get back to the place, and I forgot my link there. That's all. I'm right here. Here we go. All right. So another clinical thing that I wanted to bring up, which I actually have already brought up to you in histology when we did the ear, is a vestibular schwannoma, or acoustic neuroma, is commonly referred to, but although it's a schwannoma because of Schwann cells, are actually replicating out of control. And so it's a tumor of the vestibular portion of cranial nerve 8, and it usually shows up here at the angle, the cerebellar Pontine angle. But in the area that this tumor is located at, it can cause problems with the medulla oblongata. And so it's sort of a clinical correlation that's brought up in one of the texts that I read. And so this was the slide that I had. This young lady was talking about her story in her YouTube picture from video from histology, just in case you want to review that, because this is something real that a lot of people end up with, relatively common as far as common pathology goes. Okay, so you learned to retrieve it. You already know these answers. I know you do. Let's end this here. Identify the highlighted structure. Just look at the choices given. Okay, look at the choices given and think about what this could be. Got it? Okay, most of you have answered. 5, 4, 3, 2, 1. Wonderful. Very, very medial. The most medial nucleus, right? Medulla oblongata, super tight in towards that central canal. Ready? Which level of the medulla is this? Ooh. Think about the clues I gave you. Make a guess. 5, 4, 3, 2, 1. Okay, good. Most of you got it right. Motor decussation. So what's one thing that tipped you off to that? Yeah.
The shaded part right there.
The shaded part of the fibers crossing? Okay, so you knew it was the decussation.
Yes.
But how did you know it was the motor, not the sensory? He says, don't you see the fourth ventricle starting to form a little bit in the sensory? It probably the central canal probably widened a little bit. Okay, that might be one thing. Anybody else got something? Because it's ventral. Okay, yeah, the lines are much more ventral. Yes? Hypoglossal motor nucleus is highlighted. Yeah, that was also on the slide of the other one. Anybody else? Yes? You can still see the fasciculi of the cunate and gracilis? That's exactly what you're trying to say. That's very good. Yes, they're still there. So you know these fasciculi are still there, so you know that it's not all nucleus crossing the sides. One more thing, anybody? Yes? You don't see the corticospinal tract. Okay, great. Identify this highlighted structure. Bless you. Okay, 5, 4, 3, 2, 1. Fantastic. 89%. Medial lemniscus. Did you think you were going to leave today and already know where the medial lemniscus and hypoglossal was? No. Corticospinal fibers decussing? Okay, so it's the medial lemniscus. How do you know it's the medial lemniscus? I guess it's up and down. Because you met this tract like it's your friend. It's your new friend. The medial lemniscus is like a cell with a personality type, right? We talked about like Daredevil and the Hulk. Well, the medial lemniscus is your new friend. Okay, every slice you're going to find it except for the ones inferior to this. And what signals are these fibers carrying? Medial lemniscus. 5. Ooh. The last 20 of you, make a guess. 4, 3, 2, 1. All right, 87% vibration and proprioception. Because what's carrying pain and temperature? The anterior lateral system. What's taking motor to skeletal muscle or the spinal cord? The cortical spinal tracts. Don't forget it. Don't forget it. Thank you very much.